Good evening, everyone. I thank Dr. Purva for giving me this opportunity to today speak on the topic of genetics of kidney disorders. And during the session, I can take the questions, or at the end of the session, we can discuss the questions that might arise from this presentation. So, if we go to the background of kidney disorders, so there are about 10% of all adults and nearly all children who receive renal transplant therapy have an inherited kidney disease. And it is the fifth most common cause of end-stage renal disease after diabetes, hypertension, glomerulonephritis, and polynephritis. Rare kidney diseases constitute at least 150 different disorders. Patients often have compromised health with a poor quality of life. Now, how do this condition may be genetic condition? They might either be monogenic or they may be polygenic. So what is the difference between a monogenic conditions and a polygenic condition? If we go with genetic causality wise, then a monogenic recessive condition will always have strong genetic causality. Whereas if it is a dominant condition, it will have intermediate genetic causality and it will always be poor in case of a polygenic condition. If we go to penetrance, then we'll see that a autosomal recessive monogenic condition will have full penetrance, whereas a dominant autosomal recessive condition may have sometimes incomplete penetrance, whereas a polygenic conditions will always have weak penetrance. And age of onset in case of a autosomal recessive monogenic condition it may be in utero, in the fetus itself, childhood, adolescent. Dominant condition will always be in adulthood, whereas a polygenic condition will always be in adolescent, or adult. If we have to do a testing for a monogenic condition, so you can directly do the direct exome sequencing from the known disease gene. So we know the gene which causes a particular condition. So we know for UMOD, we know the disease that it causes, TKD. So we can directly sequence that known gene. So direct exome sequencing of the known disease genes can be done in a autosomal recessive dominant condition. Whereas in polygenic condition, only assignment of respective value is possible. If it is a monogenic recessive condition, it is rare. Hardly we found one case in 40,000. Whereas it is rare in case of dominant condition also, it will be 1 in 1,000. And if it is a polygenic condition, it is frequent. You will find this in 1 in 5 cases. So all these data was taken for publication on Lancet from 2010. Now, how do these genetic conditions inherit? So the inheritance will be only by these 4 methods that I have described here. Which is relevant for our nephrotic diseases. So it may be autosomal dominant. Each affected person usually has an affected parent, occurs in every generation. A good example is ADPKD, autosomal dominant polycystic kidney disease. Autosomal recessive condition, both parents of an affected person are carriers, not typically seen in every generation. The example is congenital nephrotic syndrome. X-linked dominant, females are more frequently affected, can have affected males and females in same generation if the mother is affected. So an example is steroid-resistant nephrotic syndrome. X-linked recessive condition, where males are more frequently affected. Affected males often present in each generation. Again, the example is SRNS. SRNS can be inherited both in X-linked dominant way or X-linked recessive way. Now, what are the different genetic nephrotic disorders? It may be renal, cystic, and interstitial diseases. So we all know, being nephrologists, all of us, we know what are different renal, cystic, and interstitial diseases. They are polycystic kidney disease, tubulointerstitial kidney disease, ADTKD, Joubert syndrome, and related disorder, nephrocon. So all these have genetic background. Renal tubular diseases like Butter syndrome, Gitman syndrome, hypoaldosteronism type 1 and 2, Fanconi syndrome, distal renal tubular acidosis. Renal glomerular disorders, steroid-resistant nephrotic syndrome, familial atypical hemolytic uremic syndrome, Alport syndrome, fibronectin glomerulopathy. Nephrolithiasis, primary hyperoxaluria, cystinuria, hereditary xanthenuria, and Den disease. C-code, congenital abnormalities of the kidney and urinary tract. So what are the conditions? Renal disease, renal agencies, renal hypodysplasia, multicystic renal dysplasia, vesicoureteral reflux. So all these conditions have genetic background. Now, what are the different targeted tests for kidney disorders? It will be for polycystic kidney disease gene panel, ARPKD, PKSD1, ADPKD, PKD1, and PKD2. Meckel-Gruber syndrome gene panel, VHL gene analysis, von Hippel-Lindau syndrome, recent replication analysis, Zoubert syndrome gene panel, Bardet-Biedl syndrome gene panel, TSC1, TSC2 gene panel, Bartter syndrome gene panel, atypical hemolytic uremic syndrome, primary hyperoxaluria, homocystinuria, clinical exam, whole exam as the requirement may be, and we also have nephrotic syndrome gene panel. Now we also do HLA typing. So if we go to HLA typing, so we need HLA typing in mostly we need in the transplant cases. So HLA typing is used to match patient and donor for organ transplants. A good match also lowers the risk of complication after a transplant, such as organ rejection. HLA typing by next generation sequencing generates unambiguous phase resolved HLA typing results using a single assay system and analysis program. So it is comprehensive. Only one test will give us the best solution in case of a transplant case. Benefits of NGS-based HLA analysis. HLA region is the most densely polymorphic region of the genome. Sequencing HLA genes used to be notoriously difficult due to a high level of sequence homology between HLA genes and pseudogenes. NGS sequencing by synthesis chemistry overcome these challenges, enabling simple high-quality analysis of the key HLA genes. Now, this is a case scenario. So, this was a 12-year-old male. So, he was having medullary nephrocalcinosis with hypercalciuria, hypomagnesemia, hyperuricemia, polyuria, and polydysplasia. So, he was suspected to be having familial hypomagnesemia with hypercalciuria and nephrocalcinosis with severe ocular involvement. It might be APRT deficiency or DAN disease or primary hyperoxaluria. So once we have done the exome sequencing for this case, what is the result? So we have found that CLD19 mutation was found in this case, and we have found a likely pathogenic variant. So how to understand a NGS report? This I will show that also. So this CLDN19, this is the gene. So this is the gene that is responsible for causing renal hypermagnesemia. So this is the gene. So this is the transcript ID that has been given from ensemble. So where this variant has taken place, it has taken place in exon 4. If we see in DNA level, in nucleotide level, so there is a at 535 position Z2A mutation has been there. The nucleotide G has been changed to A in this condition, and what it has led to? It has led to the change of amino acid at this location from glycine to serine. So this is the protein variant. We know if there is a protein variant, ultimately, if the protein that you need in that particular position, if it changes due to the mutation in a nucleotide, so it might be a pathogenic condition, which has happened in this case. What is the homozygous? This is a homozygous condition. So what is the inheritance? Autosomal recessive. So this is a homozygous autosomal recessive condition. It signifies that parents might be carrier for this case. So this classification is likely pathogenic. That means this has already been reported in disease databases for this condition. However, in few number of cases, that's why it has been marked as likely pathogenic variant. So how to understand this NGS report? As I have mentioned in the earlier slide, so we describe the mutation that we found. So it will be, a report will come like this. The variant will be described. We have found a homozygous missense. What is the type of mutation? This is a truncating mutation. What is the mutation that we have found? So this is a missense mutation that has been found in the exon 4 of CLDN19 gene. So this was found in 36X depth. So we'll also write the frequency, how much it has been reported in these databases like ExaSeg. We have our internal database. We are the only organization in India for genetic testing. We have our internal database. So what does in silico prediction say? Bioinformatical in silico analysis using by different software. It says whether this is damaging. Yes, it has been found is damaging by SIFT, LRT, and mutation tester tool. So genotype phenotype correlation. Once we find the genotype, so we have to match with the phenotype. So what is the phenotype? So this mutation causes this OMIM stands for online Mendelian inheritance in man. This is a disease database where different mutations causing different pathological condition in human are listed here. So this causes renal hypermagnesemia 5 with ocular involvement as was suspected in this case. So this is caused by homozygous or compound heterozygous mutation in CLD19 gene. We have found a homozygous autosomal recessive mutation in this case. What are the complication of that may arise from this condition has been listed here, and you can find this. Just you can Google this number right now in your mobile, and you will find this like that. So once you go to OMIM, this will come like this. So the name of the condition will be there. What is the alternate title of the disease condition? All details, which is the gene that is responsible, how it inheritance, like this inheritance is mentioned here, autosomal recessive, what is the gene, is CLD19. All information can be found in OMIM. So this is a second case where a baby is presented with clinical indication of frontal bossing, low sets of ears, conical teeth, rectumclatia, epicanthal holes. So she is suspected to be affected with congenital nephrotic syndrome and has been evaluated for pathogenic variation. So what we have found? We have found a mutation WT1 gene, and this is a heterozygous mutation but autosomal dominant, and this is a pathogenic mutation. So this confirms my diagnosis that this baby is affected with nephrotic syndrome. So I was, as a clinician, the clinician was suspecting nephrotic syndrome, and we also found a mutation that is causing nephrotic syndrome in this case. This is another case. This is a 28-year-old female born of a non-consanguineous marriage, is a known case of renal dysfunction and is presented with clinical indication of hypertension, laboratory workup show elevated RBC count, mildly elevated cholesterol, and elevated levels of creatinine, uric acid, and decreased level of calcium, protein, and 25 ways vitamin D in serum. So she is suspected to be affected with focal segmental glomerular sclerosis, FSGS, with high chronicity and Alport syndrome. So what we have found? So we have found that there is variant of uncertain significance in this case. So do I need to really worry about a variant of uncertain significance, or I can potentially disregard the uncertain significance? No, since in this case we are suspecting Alport syndrome, and we have also found a variant that is Alport syndrome, that is likely of focal segmental glomerular sclerosis 5. So we are suspecting a FSGS, and we have also found a variant that is for FSGS. However, this is a variant of uncertain significance, since it hasn't been reported in disease databases, or there is lack of scientific evidence. That's why it has been classified as a variant of uncertain significance. However, the same can be, since it's an autosomal dominant variant, doing a parental segregation study, if we can seek this in the family members, if we can confirm the significance of the inheritance, this might give the solution for the phenotype that we are looking for, as it is matching with the phenotype that has been mentioned by the clinician. So all variant of uncertain significance, we cannot say this is not important for me, or this is a negative report. We cannot say that. We have to phenotypically see what the phenotype is saying and what is the genotype that is given in the report, and looking into that, we have to do the further course of action. Again, this is 8 months old baby. The baby was suspected to be affected with primary hyperoxaluria. So what we have found? So we have found a mutation in GRHPR gene. There are 2 heterozygous mutations. So this is a compound heterozygous condition that we have found, and it has confirmed the diagnosis to be primary hyperoxaluria. So how a genetic testing can help? It can give us a definitive diagnosis when we are unsure of. We have done all other tests that still we are not sure whether this disease is there in or not in the patient. Once we do a genetic diagnosis, it confirms the diagnosis of the particular condition. So as in this case, this was confirmed by doing genetic diagnosis for primary hyperoxaluria. So there are extensive test options, starting from exome-max, whole exome sequencing, clinical exome sequencing. You can do targeted panel based on the clinical phenotype that we have. And if we found a copy number variations in exome sequencing, we need to confirm this. So you can always do that by doing a microarray for this condition. So we also have infectious disease diagnosis in transplant cases. So we have all SCS post-transplant febrile neutropenia cases. We have comprehensive transplant panel, post-transplant viral panel, SCS transplant viral panel. We have all these panels covered in a test regime. And the technology used is PCR and multiplex PCR. Thank you for your patient hearing. If there is any question, I'd be happy to take the questions. Thank you.